This topic is sclerotherapy for ovarian endometrioma. I'm a president of KSL next to 2 years, so hope to communicate more. Ovarian endometrioma symptoms are pain, dysmenorrhea, and bleeding and infertility. Surgical excision is the standard therapy, laparoscopic cystectomy, but is with deterioration in the ovarian reserve. So from 1988, sclerotherapy concept was introduced. At first, ultrasound-guided aspiration sclerotherapy using needle. This is chocolate color, so we call this chocolate cyst. Needle-directed sclerotherapy was first introduced. So on the ultrasound, put the needle to cyst and aspiration as much as possible. And then alcohol injection. But recurrence rate is about 14%. It is our meta-analysis report. They used a 16 to 19 gauge needle. So 16 to 19 gauge needle is a real area. When you compare the area of the catheter 7 or 8.5 French with a needle, huge difference. So area ratio, for example, 16 gauge needle is 1. When you use catheter, it's more than 4 or 5-fold. So it is real imaging, so much larger area. So it means aspiration much better than the needle. It is first reported using catheter-directed sclerotherapy by Severance Hospital Group in Korea. 14 patients, mean diameter decreased from about 6 to 1, and no recurrence during follow-up of about 1 year. Or AMH means anti-mullerian hormone, which represents ovarian reserve. There was no difference before and 6 months later. So this kind of catheter-directed sclerotherapy was introduced in 2019, usually through transvaginal approach. On the ultrasound, insert the catheter and then aspiration contents as much as possible, and then contrast study to rule out leakage. If there is a leakage, we cannot inject alcohol. And then 20 minutes position change after alcohol injection, and aspiration of alcohol, and remove the catheter. So transvaginal ultrasound ultrasound-guided puncture is not difficult. We use this kind of needle guide and puncture through the needle guide with a 18 gauge needle like this, and then remove the inner stylet. Then through the needle insert the guide wire, and over the guide wire catheter is inserted like this. A puncture, and then insert the guide wire and insert the catheter, and aspiration through the catheter, and contrast study, and then lidocaine irrigation to reduce pain, and alcohol irrigation, then alcohol retention about 20 minutes, and aspirate the alcohol. Alcohol volume is usually half of the aspirated volume, but maximum dose, I think that up to 200 milliliter is without a problem. And I make the rule to have this session again next day. So repeat the next day. So 2 sessions, there is 2 session sclerotherapy. There is disposable needle guide here. And I use alcohol, 99.5% is made in Taiwan. Thank you for your providing this alcohol. Okay, so this is a liquid image. You can see all the ultrasound, puncture, needle like this, needle tip, and then insert the guide wire on the fluoroscopic guidance, and then over the guide wire insert the catheter. That is 7 French. When there is resistance, twist catheter on the fluoroscopic guidance, and in most cases it is inserted without difficulty. and then fully insert the catheter inside the lumen, inside the catheter cyst, and then remove the guide wire and aspirate the contents in this patient 240 cc and contrast study to rule out leakage. If there is significant leakage, you cannot inject alcohol. And then, as I told, lidocaine irrigation or also alcohol irrigation, then alcohol in this patient, about half, 120 cc was used. This is patient's right ovarian endometrioma. Before, 1 month later, 3 and 6 months later, the volume decreased significantly. Volume reduction ratio means literally reduction ratio of more than 99% was reduced in this patient. The symptom improved and AMH level a little bit decreased, but not significantly in these patients. Another similar patients, right ovary endometrioma, you can see here the size was decreased significantly. Volume reduction ratio reached more than 99% at 1.5-year follow-up. AMH was not decreased in this patient. Usually the gynecologists refer the patient with reduced ovarian reserve because surgery is not easy for those with low ovarian reserve. This patient, multiple endometrioma, left single and right side, seems like one, but there was a septum, so actually 3. In this case, we can do all 3 endometrioma sclerotherapy in one sitting, in one session. The first one, the second one on the left side, and another smaller right one. So insert the 3 catheter and then alcohol or injection simultaneously. Follow-up shows 3 months. Right side more than 98%, 99% decreased, and left side also 96%. This patient at one side, left side, 3 endometrioma. So similar for left side, first one, second one, third one. We insert the 3 catheter in one sitting, and sclerotherapy was done. Volume reduction reached more than 90% at 3 months follow-up. This patient, bilateral ovarian endometrioma. Right side transvaginal approach is feasible, but left side there is uterus between the probe and the cyst. So in the case, transuterine sclerotherapy is also possible, but in this patient, I chose transabdominal approach. It was seems easier. So transvaginal and transabdominal we can combine like this. Right side transvaginal approach, and left side transabdominal percutaneous approach done. Result was also good. So compare needle-directed and catheter-directed. We can do this both ultrasound and fluoroscopic guidance for catheter-directed sclerotherapy, and easier or complete aspiration is possible. The content is very thick sometimes. So in the case, needle aspiration is, I think, incomplete. That's why the result is not so good. Recurrence rate is higher. But catheter-directed sclerotherapy completely aspirate the contents and then alcohol injection done, so much effective. Capnography is possible with catheter-directed sclerotherapy because we use fluoroscopy. It's enhances the safety. Repeat procedure is possible. The catheter is kept overnight, and next day we do sclerotherapy again. But for needle, repuncture again. So convenience, now admission is necessary, but it can be converted to outpatient clinic. This patient right side ovarian endometrioma. First session was done without problem, but the second session next day, contrast injection shows contrast leakage. So the second session alcohol sclerotherapy was not performed because of contrast leakage, but the result was not bad because 1 month and 6 months 3-year follow-up, there was no actually free at 2-year follow-up. So when he do 2 sessions, although 1 session is incomplete, we can do higher chance of performing at least 1 procedure. This is a comparison with the surgery. 4 years ago, Severance group, hospitalization days were much shorter in catheter than surgery. Complication 0, and recurrence rate was also 0, but the surgery group shows 4% and 8% respectively. And then serum AMH level was not decreased in skull therapy, but decreased in surgery group. It is our data published this year. We treated 31 endometriomas in 22 patients, and 28 were successfully treated with 2 sessions, while 1 session was done in 3 patients due to contrast leakage. There was no recurrence identified during follow-up. AMH level was lowered, but not significantly. Volume reduction ratio, as I told, averagely more than 95% at 6 months follow-up. So in summary, 2 sessions of therapy is safe and effective. Transvaginal probe is necessary, and the capital needle guide. And we puncture with 18 gauge, 20 centimeter Chiba needle, Chiba biopsy needle, and use of user guide wire, and prefer to use a 7 French picture catheter, lubricant irrigation, alcohol irrigation, and skull therapy for 20 minutes. And multiple catheter insertion is feasible like this, and transabdominal access is also possible. I meet the patient before the procedure, interview and ultrasound and AMH checkup and procedure, and then usually 3 months, 6 months, and then recently 1 year follow-up with ultrasound in my outpatient clinic. Most suitable indications are low ovarian reserve and recurrent lesion after surgery, and diameter should be more than 3 centimeters for technical feasibility. However, naive patients with a normal ovarian reserve or without operation are also indicated. Another indications are various, but I show 1 case of this is a huge cyst, 29-year-old female. This patient had Crohn's disease and underwent many surgery. This is a typical peritoneal inclusion cyst. Abdominal pain was very severe in this patient. I decided to do skull therapy. Long diameter was 18 centimeter, and then aspiration is transabdominal approach, 8.5 French catheter insertion with multiple side hole, and more than 1 liter was aspirated. And I did skull therapy with 100 cc, and 4 months follow-up shows it markedly reduced, and 22 months follow-up shows actually no. So patient symptom has gone. So this is very useful. Thank you for your attention.